Hello, micro friends, and welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. And if this is the first time listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, so let me be brief about today's episode before we jump into it. So, recently, the IDSA, which is the Infectious Diseases Society of America, they released some guidelines for the treatment of complicated urinary tract infections. So in the episode, we go over the updated definition of what makes an UTI, urinary tract infection, complicated, the role of newer agents, and the importance of antibiograms. We also discuss the 4-step framework for managing these infections, when carbapenems are needed, and more. It is a great episode, so let's go ahead and listen to it. Hello, micro friends. Maybe recently, if you are working microbiology or you're on social media following different micro pages, you saw that the Infectious Diseases Society of America released some guidelines for the treatment of complicated urinary tract infections. I thought, as us in microbiology that we do the testing, I thought it would be good to learn more about these guidelines and discuss them. So with me, I have some guests. I have actually 3 guests, and they are Dr. Barbara Trautner, Dr. Nicolas Cortés, and Dr. Kalpana Gupta. Everyone, welcome to Let's Talk Micro. Okay, so I thought it would be good to kind of, before we dive into the guidelines, to do like a quick introduction, just telling the audience, what you do and anything else that you want to share with them.
I'm happy to start. First of all, I'm really glad to be here with my colleagues because the guidelines depended so much on their intellectual effort and time spent. So it was really a collective effort. So I'm happy to see them here today. Um, my name is Barbara Trautner, and I'm an infectious diseases doctor now at Washington University in St. Louis, where I'm the co-director of infectious diseases. My research interests are in urinary tract infection and appropriate antibiotic use, particularly for urinary tract infections.
My name's Nicolas Cortés. I'm an associate professor at the University of Nebraska Medical Center, where my clinical and research work is actually focused on orthopedic infections. I run our orthopedic infectious disease service and our home IV antibiotics, or OPAT service. But I was, many years ago now, one of Dr. Trautner's mentees and became very interested in the treatment of urinary tract infections, and had this kind of wonderful early career opportunity to take part in the guidelines. And so thank you for inviting me.
And I am Kalpana Gupta. I am the Chief of Infectious Diseases at the VA in Boston and a professor of medicine at Boston University and a lecturer at Harvard Medical School. And I've been working on UTI for over 3 decades, have done original research and wrote the original guidelines, and a lot of the original work that we've now sort of brought together with a lot of evidence review into these new complicated UTI guidelines. So it's really a pleasure to actually, I consider Barbara one of my mentees. It's really handing over the baton. It's a great thing to do. So thank you.
Thanks, Cal. And we also, all of us want to recognize that Valerie Laverne is ill today, but she was uh, the co-chair of the panel and the methodologist that helped us with all the great methodology and evidence synthesis.
Indeed, and I hope she feels better soon. And I appreciate that. Up until right now, she was very involved in the effort to be here, so I appreciate that. So, well, thank you everyone again. And as we see, one of those things when it comes to like guidelines, there's always like a team effort, right? So it takes many people collaborating. So I thought, since the Let's Talk Micro audience is very varied, and we have professional students and things like that, it will be good to kind of just start very basic. And so maybe we can start talking about what is the purpose of these guidelines.
We had a mission to produce guidelines for frontline clinicians who manage complicated UTI and to make guidelines that are applicable at the point of care to the adult U.S. population.
Yeah, I can add some additional context, which is to say that for many years, the IDSA had guidelines for 2 other forms of urinary tract infection. So uncomplicated UTI, or acute simple cystitis, which for the longest time was sort of a pretty small box of within the world of UTIs, essentially bladder infections in healthy non-pregnant women. And then also guidelines for urinary catheter associated infections. And I think there was a great need for many years for some guidance for those more complicated UTIs in men, UTIs associated with kidneys infection, with bacteremia, with fever, all of the sort of tougher cases that people actually um, have questions and need guidance about were sort of specifically excluded from prior guidelines. And so this guideline development was kind of aimed to specifically address that.
Yeah, and the last thing I'll say is that there's been so much new data in the past decade, new trials for complicated UTI specifically, and this new approach, new definitions that were coming from a variety of places, and a new approach, individualized approach. And so it was really time to capture all of that in a guideline. And I think people use guidelines. Or the hope is that people will use them as a place to go for that evidence-based compilation of all the different strategies and decision points that you're going to be seeing in a clinical setting, and then now be able to use the guideline to address it. Just sort of as Nico was saying, is that that didn't exist for the more complicated UTI. So now there's a place to go for that, and you can rely on the evidence base that's presented in that document, which is really powerful.
Okay, thank you for that. And so, that kind of answers the question that I had next, which was, the factors that influence, the timing of these updates. And you're talking, more definitions, more information. When it comes to what the guidelines that the prior ones, how often do these, they get revised?
I can answer that a little bit because as the chair of the previous guideline, almost every year they would send me a form like, is it time to revise these? And really for 10 years, my answer was no, because there were, for the limited scope that they covered, there were no new agents. And really, quite frankly, there's not a lot of new agents now, but there are a couple now in the past year that have been approved, even for uncomplicated UTI. But for complicated UTI, which is a whole huge piece, that was going to require really this starting over approach. That Barbara really took on with Valerie, brought this big team together to make happen.
The reason we started with complicated UTI, and Cal and I had discussions about it at the beginning, is men were not included in the uncomplicated UTI guidelines because of the FDA classifications at the time. And we felt that that left an important sector of the population not addressed. So when we were going to put our effort forth, we started with complicated UTI. So we would know how to treat our men with UTI as well.
Okay, and besides that, what other specific changes were made when it comes to your classification of uncomplicated versus complicated UTIs?
Who wants to tackle that one? Nico, you want to talk?
I'll start, sure. So the way that I would phrase it is we went from having a very specific definition of this is what uncomplicated UTI is, as I sort of alluded to earlier, essentially acute bladder infection in a healthy woman who is not pregnant and does not have a fever, and everything else is complicated, to a very specific description of complicated UTI, which is essentially UTI that is associated with pyelonephritis, kidney infection, catheter-associated UTI, or UTI with systemic symptoms like fever, or other evidence of systemic infection like bacteremia. And then everything else is uncomplicated. So the reason we did this was to really focus the definition of complicated UTI on disease states which we know are associated with more severe infection and potentially poor outcomes, so that we can be really clear about who is that highest risk population, and say, hey, if we know how we can treat this population, then we certainly don't have to give folks who are in the other camp, the less complicated UTI, more intense or longer antimicrobial therapy.
Yeah, and I think the other big difference, first of all, this is something that people have been doing in the clinic for a long time. It's just capturing it in, guidance. And there's been expert reviews talking about how we should be doing this anyway, but this is, I think, the first official guideline to say, okay, this is how we should be doing it. And the big difference is that it changes the group of antibiotics that you're going to be considering, because for the more now complicated, as we've redefined it, you really need antibiotics that are going to have systemic and tissue penetration. And that puts the other camp of UTI, the local cystitis, local bladder infection, neatly into a different category where you can consider antimicrobials that don't get into tissue or into the bloodstream. And so it really, again, aligns so well with what we have to do in the clinical space. And I think for guidelines, that's really important because it allows clinicians to relate to the guidelines and to then use them more efficiently and effectively.
A lot of sources will say, it's a complicated UTI if the patient has underlying urologic abnormalities. But that's a vague phrase, and it doesn't help the clinician very much at the point of care. What did they mean by that? I mean, most of my older male patients have some prostate enlargement. Does that count? Are they automatically complicated? So, also, some people may have stones that aren't obstructing, and you may not know about it at the point of care. So, we decided to just go with things that people could detect at the point of care. The infection is systemic, as marked by signs and symptoms, or the infection is not systemic.
Okay, and as I was reading, and for the listeners, I'll put a link on the show notes so you can take your time and read in more detail. But there's something that I read that it was like the new 4-step framework, and how does that relate to like refining antibiotic selection compared to past practice?
So you have alluded, it takes a while to produce evidence-based guidelines by grade methodology. I believe we were working on this for 5 years, but the pandemic years were admittedly a bit distracting. So we didn't want to be outdated like 6 months after we did this. So instead of having antibiotics A, B, and C are what you should use, we've got a table of antibiotics, but you have to apply a 4-step process to choose among them. That's the art of medicine. It is applying these guidelines to your patient, the specific patient in front of you.
Yeah, the other thing I'll say is, while there is a wealth of really high quality data about different antibiotics for UTI, I mean, it essentially doing trials in UTI is one of the main ways that drug companies get their new antibiotics approved, specifically for gram-negative infections. And so we have a ton of randomized controlled trials for the treatment of UTI. The problem is that they're all non-inferiority design trials. So we have a whole bunch of really high quality studies that say, well, this is just as good as that. And so this was our attempt to, still base our recommendations on high quality evidence, but provide a framework that lets us select among all these various antibiotics who the research says are all sort of just as effective as one another.
And the other thing I'll add, and that's an excellent point, I think that UTI or empiric treatment of UTI, which is typically always your approach because you don't have necessarily the urine. We don't have a rapid diagnostic right there in the clinic for most UTIs, and we don't necessarily have a urine culture from, recent that you can rely on. So, in terms of empiric approach, it always has been an individualized approach, but now we've sort of again more clearly created this framework to help clinicians think through their individual patient sitting in front of them. And it really harkens back to, I think, an editorial even that I think Barbara, you and I wrote many years ago. It's sort of the individualized approach to patients. And this now brings in all of that information studies that we have in terms of risk factors for resistance and how do you take the person sitting in front of you, and with antibiotic X being equal to antibiotic Y in clinical trials, how do you choose between them for that patient? And I think hopefully again it'll resonate with clinicians out there, so now they might even recognize it. They might say, well, I was already doing this. But this guideline, I think, very nicely creates priorities. Like, what do you prioritize in terms of the patient sitting in front of you? The fact that they traveled or the fact that they used that antibiotic last week. So I think it's just helpful from that perspective. And I think that's going to be one of the most usable pieces of this guideline.
Okay, and and this is something that I enjoy learning about. And in the lab we do our testing, and based on we have our CLSI recommendations. Based on the organisms, recommended antibiotics. We do the test and we put the results out there. Now, when it comes to treating the patient, and you already started touching on this, your antibiotic selection. How does it differ for complicated UTI with sepsis, with versus without sepsis, and also when it comes to choosing like third or fourth generation cephalosporins, carbapenems, or fluoroquinolones in these cases?
Well, the big difference is sepsis with or without shock versus no sepsis is where we placed carbapenems. That's really the main difference. Carbapenems are in the sepsis group as preferred, but in the alternative group is without sepsis because of antibiotic stewardship considerations. I think what we want people to do is use the four-step process to help fight maybe their own intrinsic biases. Like if you don't have a lot of fluoroquinolone resistance where you're practicing and your patient hasn't been exposed to it and they have a systemic urinary tract infection, that may be the right drug.
It's worth pointing out that a lot of the data that we point to later in support of early use of oral antibiotics and shorter courses of therapy for complicated UTIs really come from studies that predominantly used fluoroquinolones. And so, although often resistance is an issue, when it's not, this is one of the more evidence-based approaches to treating complicated UTI.
Okay, and actually, speaking of that, when we talk, like the guidelines recommend some shorter durations of therapy, as you mentioned, 5 to 7 days in many cases. Maybe you can talk a little bit more about this, which patient populations are appropriate for this course.
I think, first of all, this was a area of a fair amount of work and discussion. And I think that there are some good studies out there, and people have put that together. There's a very nice graphic in this guideline, and demonstrates. And then we brought in other studies. It really demonstrates very nicely that shorter 7 days compared to longer 10 or 14 days is really quite effective and safe and optimal for most cases of UTI. There are certain areas where there's, I would say, some controversy in the data or lack of clear data, and that is specifically in men who may have prostatitis, because there you might need to use a longer duration. But really, for everything else, including bacteremia from UTI, 7 days has been very nicely with independent randomized trials shown to be the right duration. And this concept of shortening our durations in ID, you'll see, again, is repeated even in other infections, and it's a very important area for us to continue to learn and continue to apply and continue to educate, because there still is, as I see out in the field, some discomfort with this idea that you can use a shorter course. So it's a great place for the guidelines to now be our standard, and for us to teach off of those guidelines that you can. We look at both failure and recurrence. You can use 7 days. It does matter what drug you use, and it does matter the patient in front of you. So you have to think about those things.
And to give some perspective, our literature review identified 10 different randomized control trials that compared 7 days or fewer to longer courses for complicated UTI. And those studies included studies of UTI in men, of febrile UTI, of bacteremic UTI, of pyelonephritis. Our meta-analysis, we found that the shorter course of therapy, the 7 days or less, yielded the same rate of cure, same rate of relapse, and actually was also associated with a shorter length of hospitalization, which is not surprising. And then within that, there were 3 clinical trials that specifically looked at folks with gram-negative bacteremia, largely of urinary origin, and again, found that 7 days was just as good as longer durations. So this is pretty high-quality evidence that this recommendation is based on.
Okay, and one thing, and I want to talk a little bit about the antibiogram It's also mentioned in the guidelines, and maybe we can start with some definitions about like what makes an antibiogram like local, recent, and relevant, as the guidelines suggest.
We wanted to acknowledge with that antibiograms are not the same and not the same level of quality or helpfulness. Uh, if you are seeing patients with complicated UTI on the hospital ward that are kind of general medicine admissions, and yet your antibiogram was developed completely from the cancer center adjacent to this ward that does bone marrow transplant, your antibiogram may not be relevant to your general medicine patients. If it wasn't done within the last year, it may not be recent enough. If it didn't capture enough organisms, it may not be relevant. I look askance when they send me one that like they only looked at 35 E. coli. I'm like, well, that doesn't necessarily tell us enough. But the real problem is, how do we know the antibiogram applies to that patient? Just because I'm admitting them through the emergency room in Houston for their UTI doesn't mean they didn't just fly in from Boston or another country that day. There's a big difference when they are a kidney transplant patient versus this is their first UTI ever. So it's the applicability of the antibiogram to the individual patient was what we were finding it hard to find an evidence base for.
And the other thing that we should sort of point out is that, the actual evidence that using antibiograms to pick antibiotics for patients improves their outcomes is really poor. And in fact, as we were developing these guidelines, there was a large study of antibiogram use that actually found it probably didn't improve adequacy of empiric therapy. And so there is, a segment of the community that suggests that maybe this is not a useful tool, and maybe in fact we're actually promoting overprescribing. And so our sort of concession was to limit the use of the antibiogram to the folks who are at highest risk of a poor outcome with initial inappropriate empiric therapy, which would be our patients with sepsis and septic shock, for whom the margin of error is slimmer, and there's at least more of a theoretical basis that using the antibiogram to improve the adequacy of empiric therapy would translate into better patient outcomes.
Okay, thank you for that. Actually, that was my next question. So those of you that are listening and you work with urine cultures, sometimes you get this urines that like catheter urines, and you can get like multiple organisms. And how does that translate to like the clinician? So how should they interpret urine cultures from cath patients when you're considering treatment?
Well, when we're not writing complicated UTI guidelines, Cal and I like to write chapters about catheter-associated urinary tract infections, such as for up to date. Let me take this back to the guidelines, though. We got a lot of comments about why did we put catheter-associated UTI in the complicated category? Why can't you have an uncomplicated catheter-associated UTI? Well, again, we're deciding between the infection went beyond the bladder or not. And I would really like to know what symptoms people are using to define catheter-associated UTI if it's not a systemic symptom of fever. Because, for the most part, they're going to have some discomfort from the urinary catheter, but that's not really dysuria. And they're not going to have frequency or urgency because they have a catheter in place. And it's really so. In other words, there are no localizing symptoms to tell me that the catheter-associated UTI is just a simple bladder infection. So that is why we felt that it is primarily a complicated infection. Now, that said, can you possibly have an infection confined to the bladder with a catheter in place? Yeah, I think so. But I really want you to ask yourself, if you want to treat what you think is simple cystitis with a catheter in place, do you need to treat it in the first place? Are you dealing with asymptomatic bacteria? Now, for the multiple organisms, that's interesting. I assume we're talking about patients that have been catheterized for a period of time. They will all have bacteria. And the more sequencing you do, the more organisms you will find. Our standard culture methods may pick up the one or two predominant organisms, but if you do sequencing, they have multiple organisms. They have it all the time. So the clinical significance of the secondary organisms is a little hard to determine. How did you want to comment more on that since you have mentored me in that field?
I think you captured it really well. I think that, taking it back to the microbiologist, when you see a lot of organisms on a plate, the same way that you've been taught where you worry about contamination, really, really, is that's what's happening in the bladder when there's an indwelling Foley and it's been sitting there. There's just a lot of time and enrichment for bacterial growth. And so there you really need to, as the clinician who gets that result back, say to yourself, okay, what's happening to this patient clinically? And if I really think they have a UTI, then how can I get a better sample that actually tells me what is the causative pathogen for whatever, clinical syndrome is presenting to you? And you have to be careful because this is something we all teach, is urine is, if you look enough times, the urine's going to be positive. So the microbiology cannot tell you whether there's actually an infection. It tells you whether there's bacteria there, and you have to take that back and look at your patient carefully and make sure you're not missing some other completely unrelated infection, which we've all seen happen. Because I don't want to say it. I mean, it is easy to get a urine compared to some other bodily fluid, including sputum and even sometimes easier than getting blood, and the blood may not be positive. So the urine will often be positive, but you can't anchor on that.
I really think it's an open question about the concept that you should change the catheter before you collect the urine culture. We'd love to do a good research trial on that because I think what happens when you change the catheter is mainly you decrease like the concentration of some of the organisms because you've got a fresh catheter, but the urine still has all the same things. And so you decrease the workload for the micro lab, working up all those extra things, but is it really changing anything about what's in the bladder and what you should do clinically? We don't know. So in our spare time, we'll be designing a clinical trial to test.
Well, thank you for that. And so let's talk a little bit about, the newer agents, newer antibiotics and kind of like for the audience. And so we have like some of these new agents that we should use them as a last resort, and it shouldn't be like the first thing that the patient gets treated with. So when it comes to the guidelines, recommending the use of traditional agents over newer antibiotics, can you talk more about the reasoning behind that?
I mean, there are a couple factors at play. The first is simply antibiotic stewardship. I know that cefiderocol got its FDA approval for complicated UTI, but um, we should probably be reserving it for serious life-threatening infections due to highly drug-resistant gram-negative infections. The next issue is cost. I mean, if you compare Bactrim versus one of the novel beta-lactam, beta-lactamase inhibitors, we're talking about the difference between $10,000 a week for a course of therapy. And then, although I don't know that we explicitly stated this in our reasoning process, these older drugs have the benefit of a larger and longer body of experience with safety and tolerability. And so I think we should probably have a really good reason to pick one of those alternative agents.
There are just so many cases of complicated UTI if we start using the brand new agents when they're not really needed for the run-of-the-mill complicated UTI, then we won't have them when we really do need them, which is those highly drug-resistant organisms. We got rid of a slide that we originally had in our presentation that showed that the cost of, one of the preferred agents is like the cost of a cocktail versus the cost of one of the novel agents for the treatment course is like a new car. So there's a difference between those two things.
Before I ask my last question, which is something that I enjoy hearing the answers of the different guests. When it comes to these guidelines, is there anything else that you want to add, or?
So much. I'll start, then they can start. So first of all, I want to say that we had a panel. The panel worked very hard, and it was definitely a group effort. But we also had a lot of input from a lot of other groups. So to make it clear, our reviewers, at one point I thought, I wonder if there's anyone out there who hasn't served as a reviewer for the guidelines, because there were a lot of reviews. We had the IDSA Board of Directors. We had the IDSA Standards and Practice Guidelines Committee. We had the IDSA Quality Subcommittee, the Centers for Disease Control, 3 external reviewers, 9 societies, such as, American Society for Microbiology or Society for Infectious Diseases Pharmacists. Then we had patient representatives. And then after all 3 rounds of reviews with those groups, we put it up for public comment. And we got really I got an Excel file back with 1,000,000 rows in it. So we got a lot of comments. And we use that to shape these. So it's a very much a group effort.
Yeah, I mean, I think I would add that we've done our best to make guidelines that are practical and usable at the bedside, and also to write them in a way that they are as difficult as possible to misinterpret. We tried to make it really easy to do the right thing. And certainly one of the things I learned, having never written a clinical guideline before, is how much to it there is beyond simply doing the literature review and applying the whole grade framework, which is not an easy task in its own. But moving beyond, okay, this is what I've decided the literature says, to try and crafting recommendations that are useful and not likely to, mislead folks or drive the standard of care in the wrong direction.
Yeah, I think that's really well captured. And overall, I would say that this was a very inclusive process, and we tried to include viewpoints from so many different specialties and societies and perspectives, including patients. And that, as Nico said, we want this to be something that's enduring and applicable directly at the bedside. And we're kind of looking forward to seeing that happen.
Okay, well, thank you for your thoughts on. So for this last question that I have, I enjoy hearing the different answers, and we in this community, whether microbiologists, pharmacists, infectious disease physician, maybe we have this particular organism that we tend to like and maybe consider our favorite one. Maybe there's a significance to it because you have worked on it, you have done studies, you work with it in school. Maybe it's a mechanism, maybe it's a visual thing. So we all tend to have this favorite book. So I'll start with you, Dr. Cortez, and then work our way around the room. What is your favorite book?
Well, I don't know if it's my favorite versus, my nemesis, but, as I mentioned, I do mostly orthopedic infections, and so mine would have to be Staph aureus, which caused me no end of consternation, and I also probably pays for my mortgage. But it is so tenacious, it causes such severe metastatic, life-threatening infections in perfectly healthy people. It loves sticking onto all of the foreign bodies that my surgery colleagues put into their patients to improve their quality of life. And it just causes me such a headache. And it is, trying to stay ahead of it is turned out to be my life's work. So I'd say Staph aureus.
What a great answer. And moving forward, I will want to rephrase my question and maybe favorite or nemesis, as you said. That's a good way of putting it. Okay, so what about you, Dr. Trautner?
Oh, you shouldn't have asked me. I love all animals, even the very small ones. So I love all the bacteria. It's not really their fault. They're in the wrong place and we have to kill them. It's just kind of sad. But so I like the bacteriophages. I'd be a toss up for me between E. coli phage T4 or T7. I'm currently studying phages as an alternate approach to antibiotics for E. coli bladder colonization.
That's a great answer. And what about you, Dr. Gupta?
Well, for me, it would have to be lactobacilli, and that's because I worked with lactobacilli, when I was a fellow in the lab. They are really important commensal bacteria, and for me, it's not just about what they do, but also what they represent, which is an understanding of our host microbial defense system that is so critical, and I think is an area of incredible growth in terms of knowledge and research as we go forward. And maybe the answer to so many of our problems with antibiotic resistance, if we could really use our own natural host defenses. So I've spent a lot of time with lacto, and I really do have a special affinity for them.
Another excellent answer. Well, everyone, once again, thank you so much for this. Has been so great, and shining a light on these guidelines. And as I said, for the listeners, I put a link on the show notes so you can read them in more detail. But thank you for taking the time to be in Let's Talk Micro.
Thanks for inviting us.
Yeah, thanks so much.
Thank you.
My pleasure. Well, there you have it. I hope you enjoyed this episode. As always, I enjoy sharing this with you, and this is some great information. And It is great connecting, right? What happens with the tests that we do. We run those urines, we do susceptibility testing, and learning about the therapy decisions for the patients. It is great, right, to connect those things. So thank you to my guest for taking the time to be in the podcast. And, shout out to the IDSA. And hey, if you're attending ID Week this year, I'll be attending, which is in Atlanta, Georgia, from October 19th through the 22nd. So if you see me, stop me and say hi. Well, as always, you can find us on any podcast platform. So if you go to Apple, Spotify, Amazon Music, GoodPods, you can find Let's Talk Micro. So please subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. As for our socials, you can find us on Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and there's an email, which is letstalkmicro@outlook.com. I also invite you to check out the website, which is letstalkmicro.com, where you can find study resources for certification, you can find episode updates, you can provide feedback, and more. So either via social media, via email, via the website, you can give any feedback, any topic suggestions. As always, they are welcome and appreciated. If you want to support us in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI, both links available on the show notes. And I have a question for you. Are you struggling with learning antibiotics? Would you like to learn more? Well, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear audience, is the end of this episode. I hope you enjoy learning about the guidelines for complicated urinary tract infections from the IDSA. As always, I enjoy sharing this information with you. It is great connecting those dots, finding out what happens beyond the lab. It is fascinating, and this is why I enjoy doing this so much. So, thank you so much for the support. If you have stayed all the way to this moment listening to this episode, I want to share something great with you. The Let's Talk Micro podcast passed the 200,000 downloads. Hey, this is all thanks to you. You have taken the time to listen to this podcast and support it, and I am so grateful to you. Thank you. Thank you for listening. Here's to 200,000 more. Thank you again. And please continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.